It's now my pleasure to introduce Nirmal Veeramachaneni, who is a assistant professor in the Division of Cardiothoracic Surgery, does mostly lung cancer surgeries, and he's going to talk to us about the all-important results of lung cancer screening and the hazards of incidentally discovered pulmonary nodules.
I'm going to compete with Dr. Godley for perhaps one of the more controversial talks, and I intentionally titled this talk, Lung Cancer Screening and the Hazards of Incidentally Discovered Pulmonary Nodules. This has gotten a lot of press in the last year, and I should note that this is perhaps one of the easier talks to prepare, because up until the last 12 months, this would have been a very easy talk with one slide in which simply said, don't do it. Now I have one study to discuss, and we're going to spend about 15 minutes talking about some of the hazards of jumping on this bandwagon. As everyone in this room is aware, lung cancer remains one of the leading causes of death in the United States. And remarkably, 5-year survival has changed very little from the year I was born to 2000. And this is because most lung cancer that we get or discover is unfortunately at a much later stage. Very few lung cancers that the surgeon treats or the oncologist ends up seeing are actually localized. And we know that localized disease is the most treatable. Therefore, the goals of any screening program are to try and detect asymptomatic patients in a very early stage. And the idea is to provide benefits to treat patients with early stage, and any screening modality should not have excessive harm. So prior to 2011, this is a brief summary slide of 30 years of data. What we basically showed was that one could detect more cases of lung cancer. You could resect more, but there was absolutely no difference in mortality rates. And potential explanations, which other speakers in this session have alluded to, are lead time bias, length time bias, or over-diagnosis bias. And mortality is really the metric that we need to work on. So to briefly review, lead time bias, survival might be better because we detect them earlier even if death is not delayed. Or length bias, survival appears to be improved because of the relative excess of very indolent screen-detected tumors. Or overdiagnosis, survival appears to be improved because of detection of pseudodisease, which is a very common problem with lung cancer given the high prevalence of benign lesions. So we have attempted to use chest x-rays and sputum cytology since the late 1960s through the early 1980s, and none of these trials demonstrated screening to improve mortality as the outcome. The Mayo Cancer Group showed screening improved 10-year survival, disease-specific but not mortality, and that was the leading study, and that was in the early 1980s. The PLCO, which Dr. Godley presented data, at least from the prostate standpoint, this was a large study done between 1993 and 2001. 150,000 patients were randomized to yearly chest x-ray or usual care for 4 years, but then they were followed for a 13-year time point. Patients between the ages of 55 and 74 were eligible, but only 20% of these patients would have been eligible in the one positive study that we're going to discuss. And the bottom line, again, is that chest x-rays really didn't help. Even in those 77,000 patients who were intending to get a chest x-ray, 10,000 never got screened. And also we are evaluating an intervention that consists of a chest x-ray for 4 years and seeing what happens over a decade later. This might be a pebble in the pond sort of effect, and the ripple is really lost at 10 years. So the question is this way too long follow-up for the intervention to have any meaning? So this was essentially a negative trial that showed that chest x-rays were no better than usual care, which is see your doctor on a yearly basis. In terms of using CT scanning, and I'm not going to belabor this with all of the trials, but I'll just highlight a couple of them. The DANTE trial was a randomized controlled trial in Italy using CT scans. Approximately 2,500 patients who were randomized with a mean follow-up of 33 years. So cancer was detected in approximately 5% in the screen group and 2.8% of the control group. There were more stage 1 tumors in the screen group, and 20 patients in each group died of lung cancer, and approximately 25 died of other causes. So again, this study simply illustrated what we know. If you look for something, you might find it, but in this trial and the other large randomized trials, it really didn't make a difference in terms of mortality for these patients. So screening just didn't work up until 2011. Okay. Then we had a significant paradigm shift. The ACCP guidelines up to 2007 recommended no specific modality for screening because nothing worked. Then along came the results of the National Lung Cancer Screening Trial. This was published in the New England Journal in 2011. And this is the graph that's the most important. Basically showed that death from lung cancer was diminished in the low-dose CT arm versus chest X-ray. This was a 2-year enrollment period ending in 2009, and 50,000 patients were randomized to either a yearly chest X-ray or a CT scan for 3 years. Patients had to be between the ages of 55 and 74, and they had to be at least 30-pack-year smokers. So patients that one would think are at increased risk. To break down the actual numbers, if you look at the CT scan, there was a positive finding, meaning there was a nodule or a mass or something that caused the radiologist to recommend further follow-up. The false positive rate is 96% with either CT scans or chest X-rays, and lung cancer was detected in approximately 1,000 patients using CT scans or chest X-ray in both arms. But lung cancer-related death, there was 247 lung cancer-related deaths in the CT arm and 309 in the chest X-ray arm. So it's a difference of 62 patients, and this is the 20% benefit that's reported. So 62 patients, 50,000 screened. Based on this, the NCCN came out with recommendations regarding how to risk stratify patients based on smoking history, occupational exposure, COPD, and perhaps secondhand smoking. And basically, they risk stratified patients who met the NLST criteria as high risk. That's between the ages of 55 and 74, with at least 30-pack-year smoking history. Or they modified it as over the age of 50, greater than 20-pack-year smoking, and at least one risk factor, such as increased secondhand exposure or radon exposure or underlying COPD. Moderate risk and low risk patients are as stratified here. And it is only in the high risk arm that there is any recommendation now for CT scans. And what is interesting about these recommendations is it's screening for life, essentially. So if you are high risk, the NCCN recommends CT scan, and if no nodules are found, continue annual CT scans until the age of 74. That is a lot of CT scans, and we're going to talk about some of the issues associated with what happens when you actually do a CT scan. If you're moderate or low risk, there's no screening recommendation. I use the NCCN guidelines because they were the first group to come out with these. Since this time, there's been a JAMA publication summarizing the ACCP guidelines that came out within the last 3 months, and they basically echo these recommendations. It's a very busy slide, but basically, if you have a solid or partially solid nodule in a screening group, and I just highlight in red, they recommend that even if you have a less than 4 millimeter nodule, you continue screening for 3 years and until the age of 74. Currently, In low-risk patients, the ACCP guidelines recommend if you have a 4 millimeter nodule, you get a CT in a year, and if it's stable, you quit screening. So this is dramatically different. You're supposed to keep going. In addition, a lot of these patients, you're supposed to continue screening regardless of any findings. The big change in thinking is there's no longer a 2-year rule of saying that a lesion is stable, therefore we can discontinue follow-up. So this is one of my favorite quotes. Here are the data, and I'm going to provide you with the surgeon's perspective. So we know that even in high-risk patients, lung cancer is infrequent and often a function of nodule size. These data come from the Lancet publication from Henschke et al. In 2009, and what we know is that the size of the lesion correlates with the risk of malignancy in high-risk populations. So small lesions, which a lot of these that you find on detection, very little of them are cancer. Lung cancer is not present on the screening studies in 30 to 50%. So by screening, I mean the initial scan that you get, you might find a nodule, but if you continue to follow the patient and the patient develops a lung cancer, it's not the initial spot that's the lung cancer, it's something else. In my own retrospective series published several years ago, it was about 40% of the lung cancers we resected weren't actually the lung cancers that we thought were going to be the problem at the initial screen. That's from the single center institutional data. And there's considerable false positives. The goal, obviously, is to avoid unnecessary resection of benign lesions. And in 2012, we have a number of modalities. PET-CT can be helpful. But PET-CT is going to be geographically determined. What do I mean by that? So if you are in the middle of the country, in the middle of histoplasmosis, the ability of a PET-CT to differentiate cancer from a benign granuloma is exceedingly poor. So that's a major problem if you live in Ohio, in Missouri, or any place along the middle of the country. CT-guided biopsy is certainly helpful, but it's not helpful for lesions that are in the center of the lung. And CT-guided biopsy has a 20% pneumothorax rate with a 5% rate of needing a chest tube. Bronchoscopy is often not helpful for small lesions that are out in the periphery. We have new tools such as navigational bronchoscopy, which I can talk to you about, but that's something that has a sensitivity about 70%. It's not perfect, and it requires a trip to the operating room. We can try other techniques such as VATS technique, but there are large areas of the country where there's no surgeon with experience with minimally invasive techniques. So a lot of patients are getting thoracotomies. I know in Europe that this is a major problem with the Nelson trial and some of the other European trials because they just don't have surgeons who are willing to tackle minimally invasive techniques, and that's certainly going to be a problem for the patient. Historically, we have gotten much better at not removing benign lesions. So these are large case series. Some of these are the basis of radiographic follow-up being mandated for 2 years. Those are from Drs. Hood and Steele back in the 50s and 60s. So if you looked at large general thoracic practices back in the 1950s, and this is excluding TB empyemas, they were finding a large number of lesions on chest x-ray. A lot of these turned out to be granulomas. And a good percentage of the surgeon's practice used to be trying to prove that something was not cancer, and they would do lots of thoracotomies. We've gotten much better. The Smith data from 2006, that's WashU data, looking at a more modern era after PET-CT imaging, and 9% of the lung resections done at my alma mater were actually for a benign process that people thought was going to be cancer. Unfortunately, right around 2003, 2004, we got much better with minimally invasive techniques. So with the increased risk of, with the increased influence of VATS techniques, the rate of benign resection has gone up. This is also from WashU, and my friend Albert was kind enough to send me this slide. So this, in red, is the data presented by Smith et al. This is that 9% rate of benign lesions. And you can see that just looking at their own practice with a robust general thoracic practice, the rate of resecting benign lesions all of a sudden almost doubled. So a number of issues that come up with this. As surgeons get better, it's very easy to fall into the trap of, this is a straightforward thing. You're in the you can tell the patient it's low morbidity. You're in the hospital for a day. You'll get to go home. So the willingness of the patient to accept risk and the willingness of the surgeon to accept risk goes down, and I think that has certainly some influence. If we look at the lung cancer screening trial, and this is looking at the patients in the low-dose CT arm. If one looks at those patients who actually had cancer versus did not have cancer but underwent some sort of surgical procedure, either a thoracotomy, a VATS thoracoscopy, or a mediastinoscopy, there was no complication in 67% of the patients who actually had cancer. There's no complication in 84%. Well, that's a lot of patients with at least one complication. 32% of the patients with cancer, and more importantly, about 16% of the patients who didn't have cancer. If one classifies what the complications were, 103 were classified as major. So to briefly summarize, you had 62 fewer cancer-related deaths, but 103 major complications. This is not in the actual manuscript, but it's in the supplement that you can find online, and this is the list of complications. It includes everything from anaphylaxis to bronchial pleural fistula, cardiac arrest, bronchial stump issues, empyema. So major morbidities. Unfortunately, there is no detailed publication regarding this aspect of the trial. Hopefully there will be one. Myself and a number of other surgical colleagues have actually asked to see this data so we can actually analyze this a little bit further to understand what's going on, and we haven't heard a response back. In short, in this trial, 16 patients died within 60 days of an invasive procedure. We don't exactly understand the circumstances of it, and only 10 of these 16 had lung cancer. So I think that before everyone jumps on the screening bandwagon, we need to have a very thoughtful approach. And to put this into perspective, I added a few slides on the UNC experience with a nodule clinic, surveillance of pulmonary indeterminate nodule clinic. I set this up a few years ago to provide a service to our referring physicians, and the idea was, if for whatever, and this is not patients who are being screened for lung cancer, it's incidentally found nodules, patients getting an abdominal CT and the lower lung feels node a spot, or some other circumstance. So what to do with these patients? The idea was to streamline management, improve quality of care for the patient, and avoid unnecessary testing. And I was able to get a team of our chest radiologist, a nurse practitioner, and we maintain a very detailed database. So oftentimes these patients have more than one lesion, and it is very labor intensive to try and figure out if it was the right upper lobe versus the left lower lobe that was the problem. So if you keep a prospective database, it's very easy to monitor the index lesion. The slides are about 6 months old now, but as of October, we started this in October 2010. I'm up to 150 patients. This slide reflects the first 118. A good number of them are non-smokers or former smokers. And the median nodule size is about 0.8 centimeters or 8 millimeters. And this was an incidental finding in 82%. It was either from trauma, evaluation for kidney stones, cancer follow-up for another malignancy, and lo and behold, you find a spot. 118 patients resulted in 246 CT scans, 32 PET scans, and 10 surgical resections. So this is a high resource utilization. You get lots of scans. And I consider myself somewhat conservative in who I operate on. I ended up taking only 10 of these patients to the operating room for a procedure. 5 of them ended up having I'm sorry, 4 of them ended up having a malignancy, 3 which were early stage lung cancer, 1 which was a renal metastasis that was incidentally found, and the rest were either interstitial pneumonia, cryptococcus, hamartomas, or granulomas, or something a little bit more esoteric. And needless to say, these all underwent a retrospective review to see if we could have done something different, but these were all concerning FDG positive with radiologist interpretation that concurred with high risk of malignancy. So I'm not sure I would have done anything different. So there's clearly a role for early surgical input and doing this in a multidisciplinary fashion. And new screening guidelines really expose a vulnerable population to procedures with considerable morbidity and mortality if you don't select your patients carefully. So to think about this in terms of Obamacare, what is the cost of a 20% reduction in lung cancer mortality? There's considerable rate of false positivity. There's considerable patient anxiety. There's a considerable need for additional testing. And obviously, avoiding unnecessary surgery is the goal, but that's also difficult. The U.S. Preventative Service Task Force has not come out with their recommendations yet. But the current recommendations are, if you screen, you should screen patients between the ages of 55 and 74 who are 30-pack year smokers. And this is from the most recent JAMA publication highlighting this. I just want to highlight what's remarked. This summary, the ACCP guidelines, basically reflects the NCCN guidelines, and the remarks are very telling. They suggest that patients should be counseled regarding the potential benefits and harms, and there are significant harms. Screening should be conducted in a center familiar with the process. And what that means is a protocol of low-dose CT imaging with a dedicated chest radiologist and a mechanism to follow these lesions. You will likely find more than one lesion, so you should be prepared in a prospective database to keep track of what you feel is important, to screen for what changes in subsequent. This is not a substitute for smoking cessation program. And currently there are no quality metrics. Okay? There are currently no quality metrics as there are for mammography to say that you are doing this properly and following these patients. And that's still the unknown. I would suggest that this is probably not the screening modality to do at in portable scanners where some people sometimes go for total body scanning for $200 or whatnot. And also, the current recommendations to continue to screen to age 74 are based on the National Lung Cancer Screening Trial. We have no data really besides that about the most effective duration or frequency for screening. So, leave it at that. Thank you.